We're looking, of course, at awareness for lung cancer, and we should be aware that it's not the death sentence it was just a few years ago. Tell me a bit about progress.
There is excellent progress, and it's mostly due to several things. One of the most important factors is the fact that we have not only better imaging, that we can detect lung cancer earlier, but also we can treat the patient better because we have more accurate, more targeting type of equipment and better technology. Also, chemotherapy, and not only chemotherapy, different drugs that are no longer chemotherapy agents that we used to use in the past can target particularly different types of lung cancer, and patients are living longer, and many patients, even with advanced tumors, could be cured. You know, this is extremely important. The other thing that is important, and I think you need to be aware, as this month, November, we are going to be able to detect cancer like you detect breast cancer. We will be able to detect lung cancer using a screening. And screening for breast cancer has been shown a tremendous, favorable outcomes, and patients being cured 95% of the cases because we do detection of breast cancer. For lung cancer, it's exactly the same. Patients will be allowed to undergo low-dose CT scan of the chest as long as they've been having a history of smoking or they're big candidates for screening, and we will be able to detect cancers that they are in stage 1. Stage 1, treated with radiation, radiosurgery, they can be cured in 98% of the cases. So things are going to change dramatically in the next years. We are seeing already, we're starting doing lung cancer patients, inoperable cases, with radiosurgery, with treatments that were only 3 treatments for patients that they have small tumors, and you could treat them with radiosurgery because they were not candidates for surgery, because they were obese, had emphysema, or they couldn't undergo surgery. We were treating those patients with radiosurgery with 3 treatments only, 3 procedures, non-invasive, and those patients now are being alive 98% of the cases. So this technologies advances and imaging advances, and the way that you can guide radiation for tumors that are moving with respiration has made a tremendous impact in lung cancer. But people sometimes they're not aware of that. And they don't come, not only that, unfortunately, it's not only the patients are not aware, sometimes primary care physicians see a diagnosis of lung cancer and they see this horrible prognosis and they don't even do anything because they don't know that there are technologies at this time that can cure lung cancer. So I think the awareness of the yes.
That brings me to my next question. You mentioned we'll touch base on the worries of your patient, but we look here, of course, at therapies which sound very much non-invasive. When you mentioned the inoperable cases, does the body just then get rid of the dead tumor tissue the way it would get rid of any? Yeah.
What happens is when you do, for example, high doses of radiation, like let's say in an area of the lung, you will get first an inflammatory process, so other cells in your body will remove them, and you may end up having 3 months or 6 months later a little scar. And you follow that patient with something called PET-CT, and then they remain active for maybe a couple of months, sometimes even 3 months, and then the nodule disappear. So, and the body, apparently, what is believed is this technology, given high doses of radiation to the tumor, what it does is the body responds with different type of components in the blood that they get rid of the tumor. And they're working actively. They don't know if they're stem cells or what type of mechanism, but they do have a lot of theories about this because it has shown not only for patients treated for lung cancer, for many other treatments, patients and therapies and tumors that they're treated with this technology respond very well. So there's a lot of studies going on that. And for melanoma, for example, you may treat a melanoma in one location, very high dose, and other tumors in the rest of the body disappear. So there's a lot of new things coming in cancer that I think they're very favorable to the patients. So it's extremely important for patients to be knowledgeable about their disease.
Doctor, you mentioned the treatment of melanoma with high-dose radiation in one area and then other tumors disappearing. Are we talking about a possible immune reaction, antibodies,
exactly.
if you will, being formed?
Yes, exactly. That's what it is. It's your body reacts, the immune system is liberating different types of, not enzymes, the cytokinins or different factors. Naming one, there could be many of them, and they're working and trying to detect which ones there are, because the cells in the body have many, many types, and to identify which ones are and which patients could respond, to the treatment. And this is something very exciting.
Yeah, and once we know the exact triggers, then we have got an extremely accurate way of dealing with the disease.
Exactly.
I would say hyper-accurate.
Yes.
Outstanding.
Fantastic. That is fantastic because it's non-invasive, and you have a patient. Now we are testing the non-invasive for lung cancer. There is a trial, there's European, U.S., that is they're comparing surgery, radiosurgery, and radiofrequency ablation. That is a little more invasive because you need to use ultrasound, you need to put a probe in the patient. The three modalities are minimally invasive, although radiosurgery is the least invasive because you don't need to put a fiducial or you don't need to put anything inside the patient. You can just track the images with the image-guided radiation. They're going to test the three of them, and we're going to soon know if they're equally effective, then the patient could be offered the techniques, either one. It's a lot. I think the field of radiation therapy is evolving as imaging is evolving, as technologies are evolving. So, and patients need to know. And doctors need to know, because unfortunately a lot of the primary care, the first physician that the patients see, may not be aware of all these advances.
And that's another reason why for a doctor the education really never ends.
For us, never ends. And I, as far as for me, I always try to learn new things. If there's something new is coming up, I wanted to do it. If I don't do it, I wanted to learn how it does and how it will benefit my patients. So I think if the patients become now more owners of their diseases, they can do much better. For example, an example, disgracing, but why are we doing so many bilateral mastectomies? There is no need. And it's been proven now in papers that patients that have bilateral mastectomies end up having lower prognosis and lower survival and lower, responses of patients that have conservative treatment. Much easier treatment, keep your breast, no need to have such an aggressive modality of treatment. But patients are not aware, patients don't discuss, they go to the doctor and they tell the doctor, do whatever you think is best for me. And that is not the case. You own your body, you need cancer, you need to give yourself time, you need to discuss, you need to be presented with pros and cons, and you need to make a decision. Is this what it fits me? Am I going to have a super aggressive treatment? I want to be mutilated if I'm a female? No. So patients need to know. Thoracotomies before were horrible for lung cancer. You have patients end up having, by the time the patient was recovered, from the surgery, the patients already have recurrent disease. So this was the normal, many years ago. Now they can go with video-assisted mini procedures, and they biopsy and they take a little mass, and then we can go and do radiation afterwards or combined therapy. So cancer treatments are much, much better.
Of course, I can understand the concern a patient would have, and you're telling a doctor, do what you think is best, because when you hear the word cancer, you automatically think a clock is ticking, and you've got to get something done quickly. You think that time is something you don't have much of at all.
No, that is something that is a terrible mistake that people do all the time. If I don't mean that you go and have a diagnosis of breast cancer and then you wait 3 months. No. You have breast cancer, you have time enough to see a team of specialists. Same thing with lung cancer. You have the time to see a thoracic surgeon, a surgical oncologist, a medical oncologist, a pulmonologist. You have to see your team. Once you see your team and you're calm, you're going to make the best decision that it fits you better. and you have to trust the individual. And also, I always tell my patients, and everything, things are operator dependent. People think I'm going to have a CAT scan here because it's closer to my home. But not all CAT scans, imaging facilities are the same. There's some of them that, the images are useless. So patients need to know, where I can trust the primary care physician. Where can I have my mammogram? Where is the best place for me to have my mammogram? Where is my best place to have, let's say now, CT for screening of lung cancer? Not all the places are going to have high-resolution CTs where you can pick up very small nodules. So it's important that the doctor and the patient speak, and it's very, very important that the patient, have the time, to digest the diagnosis, because cancer is not a fatal disease. Cancer is a chronic disease. So you have to take the steps and go through 1, 2, 3, and then make the best educated decision. And a second opinion doesn't hurt, It doesn't hurt.
And on that note, Doctor, I'm going to say thank you so much for your time. I appreciate this. It was an excellent interview, and I appreciate it.